you for your patience, and my thanks to the attendees for bearing with old age and how technology just doesn't seem to match old age. But my thanks also to Sonobuzz for inviting me here. I'm going to talk about endometrial receptivity. And as soon as I can get Delhi's pollution out of my throat, I shall be a little better off. So we're going to talk about something which causes a pregnancy to start. And let's start with definitions. And that is that embryo implantation is a highly coordinated process, and you have a blastocyst-staged embryo which attaches itself to the maternal endometrium, and then that triggers a placentation and the rest of the pregnancy. And endometrial receptivity is defined as a temporary, unique sequence of factors that make the endometrium receptive to embryonic implantation, and we shall see what these factors are. We know that implantation can occur only during a very brief, restricted period when the endometrium becomes receptive, and this is known as the window of implantation. And in natural cycles, which is those in which you have nothing except folic acid, there would be something in a mid-secretory phase, which is limited to approximately 48 hours. And it starts about the 7th day after the LH surge. And therefore, this would correspond to about day 20 to 21 of a natural 28-day cycle. When we have medicated cycles, things are different. And of course, whenever we talk about endometrial receptivity, we always remember to mention embryo quality. This is similar to what I mentioned to the same group about 10 years ago. But what we're going to talk about more today is how we reassess the endometrium 10 years down the line, and how we have more evidence to say that ultrasound remains the mainstay of evaluation. We know that this endometrial receptivity is the consequence of several changes. You have molecular changes, cytochemical changes, you have cellular changes and architectural phenomena, and all of these result in the formation of penopods, with the changes in the endometrium that you can see only on a scanning electron microscopy. Now, obviously, this is something that you can't do clinically. You cannot take a sample, send it off for electron microscopy, and within the same cycle get an answer. Also, you can't afford to really damage the endometrium beyond a point. So then what do? We look for surrogate markers, and that's what this talk is going to be all about. How much of ultrasound, how much of everything else. Remember that the stimulated cycles, which is the cycles where we are studying ovulation and doing fertility treatments, this kind of window of implantation would be at day 19 to 20, which is when the endometrium would be expected to be receptive. And in artificial cycles, which is like embryo transfer cycles or frozen embryo transfer cycles, you will be giving only estrogen to prepare the endometrium, and there the window is typically a little later, which is day 21 to day 22. Now, there are two types of things to understand here, and both of them help us to answer two very important questions, which is exactly what the gynecologist wants to know. One, why is the patient infertile in spite of everything being okay? And then, if I am doing infertility treatments, why are these failing? And the background of these is simple, that you can either have a window that gets displaced. That means it's not going to be happening at the correct time of the cycle. And that's shown here on the x-axis. Or you can get disruption of the endometrium. It doesn't respond in the proper way, and that happens on the y-axis. And you could have just a disruption, or you could have displacement, or you could have a combination of both, which is why we now talk in terms of a different taxonomy for the diseases that cause this. But that's beyond the scope of today's talk. What we will say is that irrespective of which of these questions you're trying to answer, how do we go about it? And do remember that involved in all this is the role of the radiologist to suggest treatment modalities. That means we're answering the question, but it is expected of a radiologist to have enough knowledge to actually have questions that will answer this, and not just, oh, well, this is okay and that is okay. No, that's not enough. We have to guide them. And how do we do this? It's not impossible. The first thing that we have to realize is that we have a choice of investigations that are available for the treating gynecologist. One of them, of course, is the tissue sampling, like we mentioned, to look for penopods under an electron microscope, something which is not practical in daily life. You could do tissue sampling for histopathology. You could look for beta integrins and biochemical factors. You could do serum evaluation of biochemical markers, or you can now do what is called gene expression profiling by microarray. And of course, there is ultrasound. where do we stand on this stuff today? Which is, what do we need to do? Well, when we look at things today and we do investigations, we look at ultrasound or radiology, which correctly should be called radiomics. I don't know why we don't use this word more frequently. We look at other things called epigenomics, which is beyond genetics, metabolomics, which is metabolites or biochemistry, and we look for proteins, which is called proteomics. None of these currently work so beautifully when we're investigating endometrial receptivity. What is working to a certain extent is transcriptomics, which is looking for things inside tissues and transcription of genetic material. And let's see where we stand on that. When we look at things today, we do realize that transcriptomics is still in the realm of research, and we don't have a randomized controlled trial, also that the results are not available fast enough. So we're left with two things, the ultrasound and the endometrial receptivity assay. The ultrasound in all its glory, which we will discuss, and more importantly, taking a biopsy, which is done by the gynecologist, and this is done in the right time at the window of implantation, and you set it off. And then you get a bunch of information, which is on proteins, metabolites, and so on, and they specifically look for genetics. And that tells us whether it's researchable or not. The problem is that this is invasive, that there is no randomized controlled trial today, but it is popular because some people who do good fertility treatments are using it, and they are convinced. But we still have to wait for a trial. Radiomics, on the other hand, is non-invasive. It's relatively cheaply available because ultrasound is available cheap in our part of the world because we don't sell ourselves correctly. And also because we feel that we owe the patient something, which is completely wrong. We will talk about that some other day. But more importantly, that ultrasound is quick to perform, it is reliable, it is reproducible, and it can be done on high and medium end machines, which is what all of us possess. What are the other ways of looking at the endometrium? You could look at it hysteroscopically. This is good endometrium, this is bad endometrium, but it doesn't help. And you have only one study of 61 women. No sense. What about uterine natural killer cells, which is a blood test on the mother? No studies, insufficient data, we can't do it. What I was just speaking about, the endometrial receptivity assay, says, okay, you have some data, and this is data from 2019 that I'm referring to, which still says that the data is insufficient, and therefore what we're left with is the future of something which we call transcriptomics, which is not yet available, which leaves us with what you and me still do, which is endometrial receptivity. Why is it still being ignored? I mean, we do it. You must realize that we're dealing with a falling curve of the involvement of radiologists. And why is this happening? Very simple. People who do IVF are involved in surrogacy, and there is money in surrogacy. And why bother to answer questions? Because let's face it, the Indian patient in particular is always in a rush for results, and they want to have a baby just now. They walk into your clinic, they want a baby just now, preferably even before 9 months are through. And therefore, there is a push for surrogacy. So it's something that is working negatively in both ways. There is the fact that we do not realize the value of symbols in our life, which is treatment versus commerce. Also, there is money to be made in invasive sampling of the endometrium for an endometrial receptor assay. And there is lack of knowledge by the infertility expert. They have no idea what we're talking about. They have no idea we can do these things. Also, that gynecologists and infertility specialists and patients find it very convenient to combine a clinical consultation with an ultrasound scan. And therefore, they'd rather go to one place than two places. And then there are enough amongst us who have a complete disregard for ethics. If we weren't doing that, and if we were going ethically and trying to answer questions on why my patient is not getting pregnant, and we were not looking at commerce and we were looking for answers, the commerce would follow automatically and the patients would go away the way they're supposed to go away. And we'd be able to convince them, like, don't be in a rush. We need some answers. Give a little bit of time, maybe 2 months, maybe 6 months, and we'll have answers for you. And then partially the fault lies with us as radiologists because we don't showcase our work. We don't showcase our work. Gynecologists and infertility specialists don't know how much we're doing today. Also, some of us are just not familiar and we give suboptimal reports, and so the referring doctor feels why bother to send at all. So therefore, this seems to be dying. And we have to prevent that, and we will discuss that at the end. Because we need to do something. After all, infertility is now a part of something that 1 in 6 couples encounter all over the world, and it's pretty much the same for India as well. Treatments are now complex and require more time and money, and we owe it to our patients to have something that is a more efficient system for the kind of time, emotion, and money that they invest. Also, that when you and me use technology correctly, we improve take-home baby rates, and therefore we must analyze, understand, and reduce phase cycles. And the way to do that is by doing a good endometrial receptivity study. We learned already from the speaker before me that you do follicle monitoring. That was a beautiful talk, and I do hope you will go back to it. The second step is to study the endometrium, and we study the thickness, the morphology, and the vascularization on 2D and 2D power Doppler. You study peristalsis also, and we will discuss all of these as we go along. And on 2D Doppler, we also study uterine artery flow. To these, we add 3D indices. One is the 3D endometrial measurement of volume, the shape of the cavity, and I won't discuss much on that because that is a part of quite another talk, and 3D endometrial vascularization, which we will go into the details of. So let's see what you and me are supposed to do. Let's see what you and me are supposed to convey to our colleagues and get referrals from them, and let's see how we can use technology so that we don't fast track everybody to surrogacy and or adoption. So we do understand that when the endometrium is developing, it goes through a menstrual phase in the cycle, and in that menstrual phase, it's thin. And then soon after menstruation, within a day or two, you get a triple layer, which you see as this, a central line, which is the cavity, basal white lines or echogenic lines, which represent the basal layer of the endometrium, and between them, a darker portion, which you will see better as the endometrium thickens. And all of this starts happening by about day 5 or 6, and then by about day 7 or 8, you find this wonderful layer as you see over here. Now, all of this is part of 2D evaluation, and once you have the LH surge, the dark spaces between the 3 layers fill up and you get a secretory endometrium. All of this happens because the endometrium responds to estrogen, which is there in the mother's environment, and therefore you have an increase in thickness and the formation of the triple layer. And then once the LH surge happens, like I said, you will find that the area between those darkens. You still have a skeleton of a triple layer, but the areas between the outer margins get dotty or echogenic, and you see a superimposed echogenicity on the basic triple layer. Endometrial thickness below 7 millimeters on 2D is rarely associated with conception, although some people like to use a 9 millimeter cutoff. Remember that much of what we talk today is part of IVF cycles, and a lot of endometrial receptivity is therefore assessed not at the window of implantation, but when the leading follicle reaches a size of 18 millimeters or more, or any time that it crosses 18, and also on the day of HCG administration, which more or less coincides with when you're going to be giving the HCG in your stimulated cycles. So this is what we have to do. We have to get the right time. So what if I get my patient and my gynecologist says, look, can you please do endometrial receptivity? And she's sitting on day 27. You can't tell the patient, look, she doesn't know what she's talking about. He doesn't know what he's talking about. You can do a study and say, look, the right time to assess receptivity would be when the follicle reaches a mature size, which is at least size 18, and re-evaluation is suggested on that day, and then you just charge for a 2D simple scan and send the patient off. So it's not that you will accept nonsense just because the other people don't know. Remember also that these cyclical endometrial changes always have to be seen in the perspective of cyclical ovarian changes, which Dr. Tapashri showed us so beautifully. So what she showed us was that you have a follicle that's about 18 millimeters, you have peripheral vascularity, and then you have an endometrium here, which is echogenic. There's no triple layer. So obviously there is a problem here with this thing because the follicle itself seems perfectly good. So the problem here then lies in a poor endometrium. Also, whenever we do see an endometrium that is echogenic, you have to look at the ovaries because a very similar appearance may come from a mature follicle, or it might come from a bunch of immature follicles, which then secrete together between themselves enough estrogen to excite an LH surge, which can be at random. so that a triple layer which was developing suddenly becomes echogenic, and therefore you can never interpret an echogenic endometrium or any endometrium for receptivity without looking at the ovaries. Remember that one of the biggest problems that you and me can sort out with these receptivity studies is the fact that you have a good follicle, you have good peripheral vascularity, but the endometrium is thin. You then, and I'm telling you then, which means the radiologist then must look for other clues, such as for tubercular endometritis, look for previously treated endometritis by looking at the cavity more carefully, take a history of repeated curettage, find out whether this is a clomiphene cycle, whether she's had the last few cycles of oral contraceptive pills, or whether she has an abnormal immune state, such as systemic lupus or Sjogren's disease and so on. This is part of the duty of the radiologist today, because just giving a report is not enough. Go into this history yourself, go into the file of the patient, and if the patient doesn't have enough information, do contact the treating clinician. That is the way to showcase your work and increase your work and give you good take-home baby rates. And believe me, that's good for practice, that's good for your hospital getting more patients. When things don't go right, there are estrogen receptor abnormalities, and this is what the estrogen receptor assay looks at. And the problem with the thin endometrium is that in the deeper layers of the endometrium where you implant, you usually find that the high oxygen levels there may not be good for implantation and growth of the embryo, and therefore you need a thickness so that implantation is in the superficial layer, which is far away from the deep layer, and this seems to be the most logical explanation. So endometrial thickness you do need definitely. People would say, look, what can you do if you don't find it? There are many things you can do, and I've given a list here. No time today to go through this list. We could perhaps do it as a separate talk somewhere, someday. But remember that the treating doctors have lots of choices, and that is for them to say that. Tell them, look, maybe you can just cryopreserve these embryos, maybe you can start a bit of ethinyl estradiol, it may be too late, or treat tubercular disease, or use low-dose aspirin, use sildenafil, use other nitric oxide donors, and then some of the newer things where you could also help out, such as plasma injections into the endometrium or a GCSF, and so on. So you become part of the treatment protocol, and you become part of guiding the treatment protocol, and you shouldn't run away from this responsibility. Remember that there's lots of patients, because you're doing a vaginal scan, you're spending time, they'll come up with stuff from alternative medicine, and it's nice to be familiar with some of these terms. Like if she says, look, I am taking my arginine and I'm taking donkey roots, try and remember a list like this. Take a screenshot of this, because patients then can be told that, look, maybe this works, maybe this doesn't work. Let me discuss it with the gynecologist and see what's to be done. And then remember that you will not stop at 2D. It is important today that you look at the endometrium carefully, on 2D, of course, by sweeping from one side to the other. And you see this is thinned out in parts and not so thick in parts. And then you do a 3D reconstruction, and you get the configuration of this cavity, which is a disastrous cavity. This will prevent embryo transfer. There's a big adhesion here. Then there is complete distortion of the left corneal area. There's like a cylindrical cavity instead of triangular cavity, and most of the left corneal and the right corneal area is also completely gone. And this then becomes a part of assessing endometrial receptivity, that at that point of the possible thick endometrium, it's much easier to see the configuration of the cavity, and you should use that window to use it. Remember that it might also be useful to remember that there could be Synechiae, or what we now call adhesions, in the upper part of the cavity, in the mid part of the cavity, or the back of the cavity. So if you were to do multiplanar imaging like you see here, or multi-slice imaging like on CT and MR, then you might pick up much more in one particular plane. So this cavity may not look so bad over here, which is one of the lower lines here. But as you go up and down below that, you realize that most of the endometrium is missing. So this multi-slice technique is something that is very useful. The 3D rendering is also something very useful. And the more you use 3D, the more you'll end up seeing on 2D. Remember that you can actually measure this by 3D evaluation. The programs are usually called VOCAL or VOCAL2. You sweep through the endometrium with a high-frequency transducer, preferably 6 to 12, but you could also use a 5 to 9 and use at least 7 megahertz, as you heard Tejasvi say, and then draw around, and it gives you a volume, because volume is more sensitive Also explains why sometimes you can have a thin endometrium and you still conceive, because some parts of that were thicker, and you could only see that when you went through the whole thing from top to bottom, front to back, and side to side. So the volume cutoff that we use is 1.59 ml. So if on 3D, in the middle of the cycle, your follicle is 18 millimeters, you find that the endometrium is more than 1.59 ml, you're very happy. And the usual range that we like to see is 2 to 13 ml. And there it becomes a very good indicator of good endometrial receptivity. Useful in cavities with Synechiae, useful in anomalous uteruses such as a septate uterus, and useful in adenomyotic uteruses as well, because sometimes 2D thickness is difficult to evaluate in that situation. Remember that with 3D, you have more contrastiness without using radiological contrast. And you can actually tell how much is functional endometrium, which is the bright portion, compared to scarred endometrium, which is the hypoechoic portion. And so you can actually do a vocal of only the active endometrium and find out whether that has achieved a volume of 2 ml or so when the follicle reaches size 18 or more. Peristalsis is something that you and me often forget to look at. It can be random, as you see here, which means it's not the right time of the cycle. A good receptive endometrium will show waves that start here above the cervix and gradually go up to the fundus. And typically, you should find over a 2-minute interval at least 3 such peristaltic contractions, which means it does take time, but believe me, it's truly worth it. That you see this, you wait for the wave to start, it proceeds slowly, you can see this becomes narrow, this becomes wider, then the narrowing is proceeding this way. Now this whole thing is narrow, the fundal portion is still wide, and in less than a few seconds, this wave would go up and reach all the way up. This is the receptive endometrium. 2D evaluation of peristalsis in an endometrium which is at least 7 millimeters thick and a follicle that is 18 millimeters in diameter. You then move on to vascularization, and you see whether it's within the cavity at all, that means entering that triple layer, whether it's going between the basal layer and the middle layer, and also whether it's actually reaching the cavity. And that's where you have the zones. The outer is called zone 1. Zone 4 is the inner cavity. So this is like a zone 4 vascularization. And if you don't find this, then again, several options. Delay the HCG trigger, give a little more nitric oxide donors, give a little more ethinyl estradiol, and so on. All of which should be mentioned in your report, and preferably give an image so that people understand the good work you're doing. And sometimes in IVF cycles, if things don't happen, just cryopreserve the embryos, get an endometrium ready after that cycle is done. Remember that there is a difference in natural versus ART cycles, and that is more in the number and size of follicles, but also in the endometrium. So clomiphene cycles usually have a poor endometrium, but non-clomiphene, which is our usual kind of ART, IVF type of cycles, you will find a thicker endometrium, but all the readings are to be taken with the follicle size of 18 millimeters and not otherwise. I know I'm repeating myself, but this is important because we forget this, and always put it into the perspective of a good follicle or not a good follicle. Remember that we no longer use simple power Doppler, but we use directional power Doppler for this endometrial vascularization, and we of course combine it with 3D as well. Remember also that we cannot use conventional color because we need slow flow sensitivity, and we need to be looking at omnidirectional vessels, and therefore we must use power Doppler, and preferably directional power Doppler, and some of them now use a high definition directional power Doppler. You heard a few things on technical settings, but do remember that every vendor, every ultrasound machine manufacturer has his own settings. The problem is that none of those applications experts, and if I can call them wretched application experts, seem to know what they're doing. Some of them do, most of them don't, and you really have to be careful. So I like to give an odd slide like this, which is from one of the vendors, which tells you how to do the setting, which is for PRF, power, color gain, wall motion, filter, persistence, and so on. And because otherwise, by turning the total gain on, you can make anything look very red, and you can make anything look very, very blank. So you must have the right settings and use those accordingly. And they're always vendor specific. Otherwise, you can end up like this, where not so vascular over here and completely full of vascularity when you do it over here. Now, do remember that you can quantify this and you can quantify the endometrium at the same time. So you don't have to do two sets of measurements. And the volume will then give you your grayscale volume, and it will also give you the degree of vascularization. Vascularization in infertility, again, uses vascular indices. And these indices that we employ are the vascularization index, the flow index, and the vascularization flow index. And all you have to do is to press one button. After having drawn around the whole thing, you will get a total volume, and you will get these. And what do these indices represent? VI is the number of vessels, FI is the amount of flow, and VFI is a combination of vessel presence and blood flow. And this is what people have been using for the past 10 to 12 years to try and get good answers. There is a change in these throughout the cycle, and it depends on your LH. And this is a paper we published many, many years ago. And the important thing to remember is that no pregnancy will occur if the VI is less than 1.0, if the FI is less than 31, and the VFI is less than 0.25 at the time of follicle size 18. Not at the implantation window, but at the size of follicle 18. So this is predictive of how the clinician is going to handle the cycle. Can we use subendometrial vascularization? Lots of papers about 20 and 30 years ago. And then they started disappearing from the literature. In fact, a lot of this endometrial receptivities actually disappeared from the literature simply because it takes too much of an effort by the treating gynecologist, so they don't do it, and they want to fast track all the time. We have to reverse that trend. The important thing to remember about subendometrial vascularization is that it can be there and you can have no pregnancy, and it may not be there and you have a pregnancy. So we don't really like to look at it. It's something I don't believe in, although one paper comes up every year saying you should do it. But the thing is, your window of color is open already. Just note it anyway. What about good old uterine artery Doppler in the usual location just after the cervical artery has been given off and the uterine artery turns and goes upwards? Very useful indeed. We find that if the PI is more than 3.019 on the worst side, and we used to talk about whether it was the ovulating side or not the ovulating side, and then the obstetricians took us to a question of the mean. But in infertility, we just look at the worst side, and we look at the uterine artery on that side. And if PI there is more than 3.019, then it's not likely to be a good receptive endometrium. Remember that none of these factors that I'm talking about is useful by itself. They all have to be taken in perspective, because one could be bad, two could be bad, both could be bad, but also both can be good and you may not get a pregnancy. So you need to use the whole lot, not just 2D vascularization, but 3D as well, 3D volume as well, texture, morphology, as well as uterine artery, and then you will be giving a proper report. I know that many of us as radiologists love to use scoring systems. There is one that came out this year, a couple of months ago, and it came out from a country I don't generally rely on literature from, where Zhao Zhu and Shui have done a bit of work, and some of the authors not mentioned, they happen to be friends of mine, so I managed to get hold of this paper. And they clearly told us that, look, if you use endometrial thickness, endometrial type, endometrial peristalsis per minute, and endocardial and subendocardial blood flow distribution along with endometrial volume and the VFI, and you give 1 point, 2 point, and 3 points, then if you look at the endometrium of people who've had multiple abortions and then were planning to conceive in the future, and those that had no abortions, and what was the difference? They did realize that, look, in that disrupted lot, which indicates a poor endometrium, you end up having a multimodal score of about 10.5 or less, and people with a good endometrium was 13.5 plus minus 2.21. So maybe you can use this, but I'm not sure I like scoring systems. But since you guys like them, I thought I'll include this paper, and it's available as a free download on the internet. What we really do need to see is this: an endometrial thickness, which if it's good would be at least 7 millimeters, and there's lots of studies on that, and a thinner one is not so good. An endometrial volume more than 2 ml, and I showed you how we do that. An endometrial pattern, which should be a triple layer. An endometrial blood flow, which ideally up to the cavity. Endometrial peristalsis, which I told you should have 3 such peristaltic contractions over a 2-minute period. You go on to switch on color with the right settings, and you do then the total volume as well as the 3D indices. You do a uterine artery right and left, and you realize that you don't need the hysteroscopy, you don't need histopathology, and you don't need the endometrial receptor array. And you can match these studies pretty well. And for all of these, there's very robust data, as you can see from here. It runs into thousands and not just into hundreds. So what do we need to do? We need to remember that it's not one single pattern, that we have 2D values of endometrial thickness, endometrial morphology and peristalsis, color values of endometrial vascularization with power Doppler and uterine artery flow in the conventional way, and 3D endometrial volume, configuration or shape of the cavity, and vascularization. That's what's going to give an answer. So what are my solutions that I'm offering? To make sure that we don't get ignored, you should acquire knowledge and skills, do high quality work and ensure that it's high quality each time. Because you're a radiologist, you must provide unparalleled images. But the simplest way to showcase yourself and to make your presence known and make a difference for the patient is to discuss the case with the clinician, even if you're very, very busy. Showcase your work so people know this kind of work is going on in radiology circles. And show your work in infertility, gynecological, IMA forums, and so on. Because if you develop a circle of referees, people who refer patients to you, however few in number, believe me, 2 or 3 regularly referring infertility specialists is enough to pay for your whole machine. Forget about the rest of the work that you're doing. The more you do, the faster you do it. The time taken is much less, and you realize that it's a throughput that is worth it. You must also educate other people who handle failed cases, and that includes family physicians, GPs, ART specialists who are like genuine medical people, embryologists, andrologists, and counselors. And so be a part of CME of various disciplines so that you can talk to them and let them know that this is work that you're doing. Also remember to charge for your skills, otherwise you'll be frustrated. Remember that you and me are trained to look at images than just actually have a package of pretty looking things. And that we often possess superior technology, and we must put that to good use. And therefore, this is the way forward. And thank you so much for your attention.